Hello everyone, this is Chadi Alraies from SCAI-TV in Atlanta. I'm really privileged today to be with Dr. Aditya Bharadwa. He is an interventional cardiologist at Loma Linda, and he is one of the kind of shining star in interventional cardiology. Aditya, always nice to see you.
Thank you, Shadi. Very kind of you.
So you are giving a few talks at SCAI-TV, but one of the highlights is kind of how to build high-risk program in your lab. So this is kind of a challenge, a lot of fellows as well as early career trying to juggle through, but hopefully you can give us the roadmap for that.
Yeah, no, thank you. I mean, that's always a great topic for discussion as to, you graduate from fellowship, you go into a place, and how do you sort of build a program? And I think everybody's story is a little bit different, but I can tell you from my own experience, I think the few things that I've learned along the way, first of all, I think identify what your interests are, and then you go to a place and you see where there is a niche for developing a program, and hopefully your interests match with that niche. If it's not, then you may have to do some introspection. But if it does, then that's the best case scenario, and then I would say, it has to be a very systematic approach. First of all, you need to decide whether you have the patient population to do it, and secondly, it's important to get buy-in from your leadership. I think that's very, very important. It's also important to get buy-in from your colleagues, your co-interventionists, your CT surgeons, if you're cross-collaborating with them, your heart failure doctors. Just to give my own example, we've built the high-risk PCI and cardiogenic shock program at Loma Linda, and we very closely collaborate with both CT surgery and heart failure. So having that sort of a multidisciplinary approach and getting everybody to sort of believe in your protocols is very important. Which brings us to the thing about protocols. I think having protocols in place, checklists in place, and to say that this is the way we're going to do things in our lab. Have, for example, cardiogenic shock, it's important to have an algorithm in place. High-risk PCI, it's important to have an algorithm as to when you use mechanical circulatory system in place. And I think having that sort of protocol standardizes practice, and standardization of practice ultimately leads to standardization of outcomes and hopefully better outcomes.
So you didn't mention administration.
Yes.
Where they fit in this equation?
Yeah, that's a great question, and I think you definitely need administration to buy into what you're doing. I am lucky to be practicing at an academic institution, so I don't have people asking me as many questions. They've been very supportive, but I hear from a lot of people in the private practice world that that definitely is an issue. I mean, I think ultimately it boils down to two things. First, the fact that clinically you need to have good outcomes, and secondly, financially it needs to be sustainable. And I think you can achieve both these things by making sure that you're efficient and you're doing the right things.
You're right. I mean, again, having the buy-in from your your peers,
Yes.
Cardiologists, as well to feed the program, as also to support you to be when you need the backup.
Absolutely, I think that's the key, and again, like I said, the results do speak for themselves. The first few months obviously is the time to prove yourself, but I think once you've sort of set your record good and you have good outcomes, minimal complications, people will see that you're doing a good job.
One of the questions also, sometimes I feel fellows ask when do I start? Right away after graduation, or I give it some time to prove myself and then launch it?
Yeah, that's a great question. It's a very tricky one to answer, because I personally feel that you have to start doing these high-risk cases right after fellowship. I mean, if you take a break, it's very hard to go back. I mean, you don't want to lose touch doing bifurcation stents. You don't want to lose touch doing atherectomies the first few months after fellowship. But having said that, it's a fine line. I think number one, again, you need to have your leadership on your side. Your cath lab director or whoever your program director for your interventional program needs to understand that you are skilled enough to do it and you're choosing the right kind of patients, which I think is very, very important. You have to stay within the confines of those appropriate use criteria. The first few months, you definitely don't want to be doing things that are borderline indicated or not indicated, and you definitely don't want to have a complication on those kind of cases.
Well, Aditya, thank you so much for your insightful comments about how to build high-risk program. This is very thoughtful ideas for fellows as well as early career to launch a program. Please watch this video and others on the SCAI-TV. This is Chadi Alraies from SCAI-TV from Atlanta. Thank you so much.
Thank you.